Well, thank you everybody for joining us today with Dr. Jen DeVoe for a doctor's journey to identify and address social determinants of health. We want to first begin by acknowledging with honor and respect the indigenous nations whose traditional territories the university now stands, and whose historical relationships with the land continue to this day. We also acknowledge the elders past and present, including MSU's current Council of Elders, and humbly ask for their guidance. The Valley of the Flowers has been and remains a place of learning for Native American peoples who for millennia have passed ways of knowing, being, and doing from one generation to the next. While a land acknowledgement is not enough, it is important social justice and decolonial practice that promotes Indigenous visibility and a reminder that we are on settled and Indigenous land. Dr. Jen DeVoe is a practicing family physician and health services researcher based in Portland, Oregon. As a chair of Oregon Health and Science University's Department of Family Medicine, she oversees nearly 200 faculty, 72 resident physicians, and several of OHSU's primary care clinics. Dr. DeVoe also serves as an inaugural director of OHSU's new Center of Primary Care Research and Innovation, and was recently awarded a multi-million-dollar grant from the National Cancer Institute to develop Bridge C2 Center, building research and implementation and dissemination to close gaps and achieve equity and cancer control center. While serving as the Chief Research Officer and Director of OCHIN practice-based research network from 2010 to 2016, she led the development of a unique community laboratory linking together electronic health record data from over 400 community health centers across multiple states. She and her team pioneered the use of EHR data in research, studying methods for assessing healthcare utilization by disadvantaged populations, which has garnered her national attention. She works with several teams at OHSU, OCHIN, who have a portfolio of research related to identifying and addressing social determinants of health in primary care settings and utilizing novel EHR-based tools to support this work. Dr. DeVoe completed a directed interdisciplinary studies degree from Montana State University in 1993 and was awarded a Goldwater and Rhodes Scholarship during her tenure at MSU. She completed her MD from Harvard in 1999 and an MPhil and DPhil from Oxford University in 1998 and 2001, respectively. She completed a residency in family medicine at OHSU in 2004 and a Master's of Clinical Research at OHSU in 2010. She holds a joint appointments in OHSU Department of Medical Informatics and Clinical Epidemiology and OHSU PSU Public School or School of Public Health, and at Kaiser Permanente Northwest Center for Health Research. She was also elected to the National Academy of Medicine in 2014. So thank you, Dr. DeVoe, for joining us this evening. We're really excited, and yeah, you can take it away.
Great, thank you for having me. Certainly have fond memories of being at Montana State in the honors program back in the day, which I understand is now a college with Dean Lee at the helm. And you're super lucky to have Dean Lee with you there, and I'm just very envious of this time in your lives to be studying at MSU. So this is really a journey that I've been on for 20 years since becoming a family doctor, and I'll be kind of weaving in some stories from the research work that I do that Olivia was describing, as well as just some personal experiences I've had in my practice. So we'll start out. So interestingly enough, although social determinants of health have gotten a lot of attention, they're not new. It's not a new idea, or it's not new, certainly to people in family medicine and primary care, that social, economic, environmental factors impact health. They're correlated with health. Some people prefer to call them correlates of health, but I think the common term used now is social determinants of health. And there's a video that one of my colleagues, see if I can get my slides to go forward here without too much difficulty. There's a video that one of my colleagues created that I think really crystallizes how this feels to most of us in medicine when we're seeing patients in front of us and feel very helpless in identifying, we certainly have identified, but addressing many of the impacts on their health. So I'm going to go ahead and play this. If you can't hear it, it's just traffic noises. If you're joining by phone, I'll go ahead and read the words because there's no words in this video. It's just, there are words on a page to read, but you won't hear them. So I'll read the words for those. Oh, now it's advancing my slides without me wanting it to. There we go. Okay. So thumbs up that you got the video. Today is Amber's 6th birthday. This is Amber's front yard. It is her play area, her bike path, her route to school. Because of her zip code, Amber is 5 times more likely to be sexually assaulted, 7 times more likely to be abducted, and 10 times more likely to be the victim of violence than if she lived just half a mile away. The median income in Amber's neighborhood is 30% lower than the adjacent community, even though rents are the same. Students at Amber's high school are half as likely to complete the SAT, twice as likely to drop out, and score lower in every subject than students in the neighboring district. I am Amber's doctor. Despite my access to state-of-the-art medicines and billions of dollars in medical technology, I remain unable to treat her insecurity, her housing instability, or her poverty. So again, one of my colleagues created that video, and I think we hear a lot about precision medicine and genetic code and how much progress we've made on figuring out and sequencing genetic code and targeting people based on their genome. And again, billions of dollars, actually trillions of dollars in our country go into targeting medications and treatments based on people's genetic code. And yet we're still very far behind on really addressing what's happening and how much zip code matters, such that people that have adverse social determinants of health have poorer health outcomes. And we in the medical system don't have great ways to treat them until it's very far downstream and they have out of control diabetes or out of control hypertension or are dying at a much younger age than their peers and counterparts, again, who live half a mile away. And that's in Portland in an urban area, but certainly even in Montana, there's these disparities by zip code and there's disparities by income and race, ethnicity, et cetera. So this is one of it's several years back, but one of the scorecards that we commonly receive, and I was receiving them for quite a long time. They've been updated somewhat, but still look pretty similar for a clinic that I oversee here at OHSU Family Medicine, and I was also receiving them for my own patients. So any patient that was listed as me as their primary care physician, I was getting these scorecards showing me for my diabetics which ones of them had an A1C out of control. So this is a sign of their blood sugars being too high over a 3-month time period. Their lipid or their cholesterol panel, their LDL, being out of range. So they had high cholesterol that wasn't being controlled. Their microalbumin is a sign of the kidneys spilling protein. So this is a sign that, about half of these diabetics have kidneys that are being impacted by their diabetes. And that's a sign that we need to keep an eye on them and perhaps start them on certain medications. The blood pressure one, it looks like actually a fairly good percentage are in control, but almost a quarter with out of control blood pressure. And then the last one looking at who had been started on a cholesterol lowering medication known as a statin. So every diabetic really should be on one of those. Some people have contraindications, but that circle there should look almost completely green. So we would get these every month or on a regular cadence, and it would be really reassuring in some ways if they got better, but then not great when you see all the red and blue and other places where it should be green. And then we got a little more sophisticated. Again, this is looking at electronic health record data, which again, before the first part of my career, we didn't have any of this. So this has been just within my lifetime that we have so much more data. Hearing the term big data a lot, it's true. Like the explosion in data has been amazing, and the ways that we can then utilize it to look across different patients on our panel. So here would be like someone like me who's the PCP, and all of the names of my patients down that first column, which is covered over. But then I could really look across and see like when did I have my last visit with them, who had an out of control A1C, which is in red there, who had blood pressures that were too high, who hadn't received their flu shot on time, who was overdue for certain things. And it could really help me get a sense of like, all right, like where do I need to call people into the clinic, or who do I need to reach out to? And then I started thinking more about, well, why do these certain individuals always show up as red? And I was like, of course, like as I got to know my patients, this is a person who recently lost their job and is now couch surfing with friends. This is a person whose mother just recently passed away and she's, you know, having to be absent from work a lot. She's having to travel back home to help her dad. This is the person who um, has an 8th grade education, who works at a minimum wage job and has a really hard time getting time off from work to come in and doesn't really understand all the instructions on the diabetes monitor, for instance. So I started recognizing that, like, yes, I could be doing better as a physician and really trying to get all these numbers into the green range, yet I knew that there were other things impacting the lives of many of my patients that were really out of my control, or certainly I didn't have the team that I needed in order to help patients address many of these adverse social determinants. I was meeting with one of my patients. I often have medical students with me, and this is an excerpt out of a paper that I published in JAMA, the Journal of the American Medical Association, last year, where I was really thinking about this gap between the quality metric, which is telling me like you're a poor doctor because half your patients are in red, but the gap between that metric and kind of where quality metric ends and real life begins. And so this med student and I were looking at meeting with a patient who had really high blood pressure. She was already on a few medications. We were looking at the evidence and it said, oh, we need to start her on a 3rd medication. But then when we looked another layer below the evidence to really assure us that this was the best recommendation for this patient, who I knew very well, she also had obesity, asthma, anxiety, depression, polycystic ovary diseases, a number of other diseases. And so when we reviewed the quality metric parameters for how I, as a physician, am assessed inadequately lowering her cardiovascular disease risk, there was no guidance on what about factoring in adverse childhood experiences she'd had, or ACEs. What about her unstable housing, the unemployment and food insecurity, and how to assess all of those factors into the decision about whether an addition of one additional blood pressure lowering medication would really lower her risk. So it really, one of my favorite poems from childhood, my favorite poets, Shel Silverstein, wrote the whole book, but the poem that the book was titled or based on was Where the Sidewalk Ends. And I really felt like he talks about there's a place where the sidewalk ends and before the street begins. And so that's really where this came from, is really thinking about in primary care practice, I'm at that place. And so we ultimately in this story, it's a pretty short read, so you can share these slides. It's got the link there in the title. It's easy to go online and find it. But we ultimately decided not to start her on a medication, and it kind of goes through why. But when I get that report card next month, she's going to show up as red again, right? And so there is this place where the quality metric ends and real life begins. And so I got really, you know, throughout my career, I've been really aware of this, and that's part of the reason why I was so happy to be able to go to England and travel around the world to understand, you know, how are other healthcare systems addressing social determinants better? How are they taking better care of their populations? What are they doing? And so one of my graduate courses and my thesis led me to Jack Geiger, who has actually recently passed away, but he was the grandfather of the Community Health Center program in the US and worked in the 1960s to get funding to start community health centers, which are now all over the country. And so one of the questions that I continue to ask is, how do we accelerate knowledge in this area to enhance our services and ultimately improve health? And as I said, this is not a new problem. So I had the great honor to interview Jack in the late 1990s when I was doing my doctoral dissertation research to understand what his journey had been to help develop community-oriented primary care and community health centers in the US. So I will play his voice. It's very faint because this was transferred over from an old-time cassette tape from when I interviewed Jack in the 1990s. But I will play his voice and you can read on the screen what he said.
Health services are fine. But do you think you could do something about the fact that we don't have enough to eat, the kids don't have shoes, and it's raining through the roof, and nobody has a job, or whatever? That's when we started stocking food. And that became logistically impossible, which was why we started thinking about vegetable gardens, which became the farm co-op, because so many people wanted to do it. And also, a little bit later, invented the process of writing prescriptions for food and charging it to the pharmacy budget at the health center.
So again, there's a lot written about and talked about this right now, but it's really interesting to think historically about what was being done. So this was when he first showed up in the Mississippi Delta to start a community health center down there in the 1960s, and everyone there said, yeah, well, health services are fine. You can open up a fancy new clinic, but what about the fact that we don't have enough to eat and our kids don't have shoes and all these other issues that were impacting their health and their community? So my journey led me to, after graduate school and meeting with Jack, and certainly over time having seen all these patients that I was really struggling with, as far as, like, I know that I'm going to keep showing up as red on the quality metric, but there's all these other things going on for them, and it's not as easy as just starting them on another blood pressure medicine. I was really interested in, studying some of these issues at a national level. And around that time, there was an organization starting up in Oregon, which was originally the Oregon Community Health Information Network, or OCHIN. It's now nationwide. As you can see, it's serving 47 states. There's 5 million patients. And what OCHIN does is it provides information technology and electronic health records to community health centers, the very ones that I was studying the history of, having started in the 1960s. So it kind of came back around to community health centers, partnered with OCHIN, and created a really fun practice-based research network, or what we like to call a community laboratory, where we could partner with OCHIN and partner with these community health centers across the country to leverage the data that was coming out of their electronic health records and start asking some really interesting questions about, like, what's happening with the care of patients in primary care, and what are the factors that are impacting even in these community health centers. And you all might be familiar with them in your town or your state, but they're federally qualified health centers. They get grants to be able to see patients who are uninsured. They see a lot of patients with Medicaid insurance coverage. And so what we thought was, like, well, yeah, I mean, all the centers are struggling. I'm sure they're having challenges in getting basic work done, or basic care provided. When we did one of these first studies, though, it was interesting to see the variability. So we found wide variability. So in this study, we looked at, in the early days, they just had over 20 clinics. Like I said, now it's like over 500. But in the 23 clinics that we studied back in the early, this was published in 2013, we just asked, like, how many patients had received a service within a year. So among all their diabetics, how many of them had had their cholesterol checked, which is something that we are recommended to do every year. How many of them had a flu shot, which they need to receive every year? How many of them had their microalbumin checked? And then how many of them had an A1C, which for many patients needs to be done quarterly. So once a year would be fairly infrequent. But if you look at this, like, there was wide variability. So way down at the bottom, in some clinics, only 10% of their diabetics had received these services. And then in other clinics, almost 100% or even 100% of their patients had received the services. And then you see kind of the median line there and the minimum max in those boxes. And so it was really interesting because we were like, well, why would that be? Even in centers that see a lot of poor patients, a lot of uninsured patients, why would like some centers be getting all their patients these services and others not able to? And so we kind of dug a little bit deeper into the data and discovered that some of the variability was highly correlated with the clinic's patient panel. And one of the main predictors, at least that we were able to find data for, was that the percent of patients that had continuous health insurance in clinics was associated directly with them being able to provide the services, which is not that surprising. That, hey, yeah, the patients could get access to care, but if they didn't have health insurance, they might not have been able to afford laboratory testing, or they might not have been able to get some of the other things that require insurance. So this, I mean, I had predicted this, although it was really exciting to actually have data to show this was the case. And so I've spent a lot of my time really looking at insurance and its impact on access to health and the ability to get just basic services. And again, back on that report card, there were a few of my patients, I knew they hadn't received those things because they didn't have health insurance, so we hadn't been able to order them for them. But then once you kind of figure all that out, it's like taking action can feel really, really overwhelming. I see a question that just popped up. Do you want to chime in? Your question pops on the screen and goes away, so I'd love you to go ahead and ask it so that I can hear it.
Okay, I don't know if you want to answer this now or at the end, but
Sure.
It was just, what steps do you think we as a country should take to make healthcare more accessible for everybody?
Really great question. Yeah, let's put that on the at the end. I'll be talking about a few more things throughout the talk. And sorry I forgot to mention that, but please chime in if you have questions. And I can only see them like pop up briefly and then they go off the screen. So Olivia's gonna keep track of questions for me and we can have a lively discussion at the end. So please put lots of questions in and I'll have them kind of fly by. And if you want to interrupt me, please do so. Otherwise, we should have some time at the end. Thank you for asking the question, though. Super important. So this is, again, we know these social determinants impact health, but it feels really overwhelming. And I was, going along for 10 years like, oh, I'm super excited. I have all this electronic health record data, and I'm really, understanding where patients are missing out on getting services system. And then, of course, thinking back to grad school and some of what I learned about the conceptual model that the World Health Organization developed in 2010 to really know where, what's impacting on equity and health and well-being. I saw that I was working in that tiny little box, the health system that you can see there down in the bottom right-hand corner. And there's all these other things and all these other boxes that impact on health. And, we've heard a lot about racism and its impact on health this year. We've heard a lot about education, income. We've seen it with the rates of COVID and how it's disproportionately impacting communities that have been very disadvantaged and vulnerable over generations. And so we can see firsthand, not only with every other condition, but right now with COVID staring us in the face, all the amazing inequities and disparities that our country has continued to perpetuate over generations. So it can feel really overwhelming. There's policy and system level interventions that are needed. Absolutely, lots of policies need to change, lots of system level interventions that can be done beyond the health system, which is that tiny box. But that is definitely a topic of another lecture. And this is an old slide, I apologize, but the work that I did at the National Academies of Medicine last year led to this really cool report. It's called the Vibrant and Healthy Kids Report. And essentially you can just Google Vibrant and Healthy Kids and this report comes up. It's free to download. There's also lots of shorter resources because it's a 600-page report. But this is what I've been working on at the national level. So part of my journey has taken me well beyond my clinic and the medicine or the physician role that I play, seeing my patients one at a time in clinic, but to the national level to really think about not only what can our healthcare system do, but what can our country do to improve its health. And so this goes through a lot of different areas where there's really, really sound evidence for what should be done in our education system and how we need to do a better job with housing and food and other things. So Google this report. It's super long, but there's really good little like 4-page briefs and policy briefs about it as well. So kind of getting back to this box again, there's all these policies and system changes that need to happen that all of us play a role in, no matter what sector we're in. If we're in the education sector, transportation, housing, environment. I happen to be in the health system, and I happen to be a primary care physician and run a large network of primary care practices. So I am working in that sphere as well. So we kind of started saying, like, what can we do day to day on the front lines? What new ways can we come up with to help us better identify and address social determinants of health? And then how can we use data systems to integrate information? Especially, again, in my lifetime, I started practicing medicine when I was writing notes on paper and dictating into a dictaphone. And we had like a computer that we could look up labs. But I now can really appreciate all the new and information, new data and information technology that we have that we need to be able to harness and leverage. So our team a few years ago really put this very basic framework together of like, how can we use these IT systems? Well, we kind of like to collect the information about social determinants of health, or SDH. And you can do that, and a lot of people are, by asking every single patient that comes into your clinic or hospital every time, like questions about food insecurity and housing instability and income and education. Or you can do it with public health data. So public health and others have known about what's happening at the community level for a very long time. And so could you take what we coined community vital signs and bring that information into your health center so that you know the community context within which the patient lives? And then the second step would be, how do you want this information presented and integrated into your workflow? So do you want it when you're sitting in front of an individual patient in your clinic? Do you want it when you're looking across your whole panel and the whole population of people that you are their doctor or you are their health center and you're trying to understand, what they're experiencing? And there's arrows going everywhere, right? So there's a big debate, like which kind of data is better? Well, probably both. Where should it be used? Well, probably in both places. And then ultimately, can you do more work so that once you have that information, it triggers support and action and the ability to refer people to community organizations, to other places? Can it help you with your clinical decision support? Can it help you with engaging the patient, communicating with them differently, understanding the services that they may need in addition to seeing their physician? And this would be analogous to, like, if I see a patient who has an exacerbation of their emphysema or their congestive heart failure, I now can go into my electronic health record and either do an e-consult or a traditional consult to my colleagues in cardiology or pulmonology. That referral goes to them. They're able to address the question, see the patient, transition them back to me. But I don't have that right now ability to say, this patient, the biggest issue for them is housing. They're living in a tent down below the freeway, which hundreds of patients in Portland now do, and they need housing. But how am I going to really help get them a referral for that? And more importantly, in a lot of places like Portland, there is not housing affordable and available to them. So, that's another big area for advocacy work that some of our teams have worked on, getting some affordable housing available. And then on the research side, with my research hat, is like, this all sounds super cool, and tons of systems are doing it now, and doctors' offices are doing it, but we don't really know the best way to do this, and we don't know if it's improving health outcomes necessarily. So lots of research still needed there. But we're diving in. We've done, again, in partnership with OCHIN, led by my friends, Dr. Rachel Gold and Erica Cottrell and many others. This is kind of the approach where they're looking at, we kind of want to collect information from individual patients, but how can you do it most effectively? And then how can it be used in actionable ways? So they work to build some of these into the electronic health record chart, where different people on the team could collect information from a patient. There's others where patients can enter the information themselves if they're able to read and use technology. And so that's kind of ongoing studies. Another thing that we've been working on is, if we have an electronic health record, how can we build interventions that can be supportive? So I mentioned, like, for me, health insurance has been a big intervention that I've been working hard on, like first getting it expanded and then getting patients access to continuous coverage. So we said, well, we have all these registries now where we can follow all of our patients with diabetes and we can follow all of our patients with high blood pressure. So why don't we build a registry for patients who qualify for some of the insurance coverage that's been expanded, whether it be the Children's Health Insurance Program, which came before the Affordable Care Act and the expansion of health insurance through Obamacare. So we implemented a study where we essentially built tools into the electronic health record to identify and address patients that qualified for new health insurance products, and then tried to follow them to make sure that if they either qualified, that we could help support their application, or that they were coming up against a deadline where they were going to lose coverage, we could be proactive in helping them maintain coverage. So there's a lot of numbers on here, but what was exciting was that we had randomized clinics to get the intervention, which was this tool or the control, and then we were able to look at the intervention actually helping to increase the odds that people who were eligible for Medicaid gained Medicaid, and people that were already on it were less likely to lose their coverage. And so here, this is another quote from Jack Geiger that I really love. And it's like really just asking ourselves about how can we be most creative and resourceful in meeting the needs of patients, families, and communities, which is something we do every day in primary care, but kind of exciting to hear about the history here as well.
I'm sure I told you the story about the tractors and the backhoe. No? We're starting the farm co-op. We had this first grant of $300,000 or whatever it was to rent land from the Ford Foundation, which we were somehow running through the Federation of Southern Co-ops. And we were, in addition, going to get a grant from OEO under an emergency food program that OEO had, in which we convinced them that the sensible way to do an emergency food program was to fund people to grow the food rather than to hand it out. But that was in process. Well, the farm co-op people said, spring planting doesn't wait. We need at least 4 tractors and a backhoe, plow up the ground and do this and that. We had a guy named John Brown as the farm managers in the video. And the health center grant was just up for renewal. We were just writing it. And I said, okay, they never look at the capital equipment budget. This is maybe our 3rd year of the grant. We'll just stick it in there and put it in there somewhere. And then when we get the other grant, we'll swap the money over. And I'll explain it. So I said, okay. They said, okay. And they stuck it in anywhere. And that, of course, turned out to be the year that they looked at the capital equipment grant. And where they had stuck the 4 tractors in the backhoe was right in the middle of the section on obstetrical equipment. So I got this call from OEO inquiring as to exactly what kind of deliveries we were anticipating, words to that effect. It was hysterically funny. And I had to explain, and it became a legend in OEO. Geiger was ordering tractors for his obstetrical equipment.
So I don't know that I've done anything quite that crazy, but it's kind of gets to that effect of, like, they needed to get something done for their community to put this garden together so they had something to eat. So he put tractors and backhoes in on the obstetrics budget. Probably not something I would necessarily recommend if you want to keep your grant, but certainly creative and resourceful. Going back to sort of like what are other ways that we can bring this information in, and I tend to be an advocate for the neighborhood level data. And again, this is data, as I mentioned, that public health experts have had for generations, and they're also, I think, super excited about the new ways that we can show this data and geomap it onto maps, or look at it in really interesting ways to understand the health of a community at large, and looking at a zip code or even a smaller area to see like what's the poverty rate here, what's the median income, what's the density of food, are there food deserts, is there care accessible, are there parks and recreation and other ways for the community to stay healthy, is it safe for them to go out and use those parks, etc. And so we were hypothesizing that maybe you could take this community data and bring it in as a vital sign, so that the way that I understand very quickly when I walk into a room to see a new patient is I look at their traditional vital signs. So I know that their blood pressure and their heart rate and their respiratory rate, their temperature, their oxygen levels, I know they're in normal range, and that gives me some reassurance that this patient is hemodynamically stable. Or if I look at those numbers and I'm like, wow, their heart rate's really fast or their blood pressure's really low, I'm going to kind of have a red flag in the back of my head that, wow, this is someone who's unstable, or this is someone that we're going to really need to do some quick assessment and get them medical attention, perhaps at a higher level than at the clinic. Similarly, like, could you do something with a community vital sign such that you put together an index to know, like, wow, this person's really in an unhealthy environment? And certainly there are really rich people that live in the middle of very poor neighborhoods, so it might not be 100% appropriate for every person or vice versa, but at least it gives you the snapshot of, this person, the neighborhood context within which they live is really unhealthy. And so I know now as a physician that there is this context that we need to then think about their health. And these are, again, just examples of, what could go into that. There's like lots of ways that you can slice and dice that data. So we were just kind of curious if we were to take what our some colleagues of mine have pulled a bunch of those community vital signs together in order to create what we call a social deprivation index. And so we can then look at like what's the social deprivation index of the particular neighborhood where the patient lives. So what we did is we were initially going like, okay, if you think back to those report cards where I got like a lot of patients in the red zone, but I knew anecdotally that all those patients were not doing so well for various social or medical reasons. But if you do this at like the large population level with all this data from across all these health centers, is there either the clinical complexity of the patients you're seeing or the social complexity? Is that really affecting how well you score on these performance metrics? So this was a study where we looked at a comorbidity score, which is like kind of the number of health problems that a patient has. And yes, I have a lot of patients with 8 or more health problems. They're super sick and have really complex clinical scenarios. But then there's other people that have 0 or maybe 1. And this was interesting because what we did is we looked at like across the whole clinic system, depending upon, the comorbidity score of their patients, you could see like that they had more of their diabetics in good control. So this is kind of tricky to read, but like if there was someone with only 0 or 1 clinical problems in that population, there was only a 15.7% of their diabetes that had poorly controlled diabetes. So like that number is getting below where you would want to see it. Obviously you'd want to see it be 0, but a lot of places are like, as long as it's below like 18, 17%, we're good. But then all of a sudden you look at the others and they're all above 18%. So as a health system or a doctor takes care of, people with a lot of complexity, they're going to get to the point where they're really struggling to get their diabetes under control. And then this one took just those people in that one category where they had, 2 or 3 chronic conditions and their Charlson index was 2 to 3, and compared like if we took everybody within these community health centers and we did no adjustments for social complexity, the percentage of diabetics in poor control would be almost 20%. And let's say you were an insurance company and you were telling this clinic, like, if you don't get the percent of patients in diabetes, so percent of your patients with diabetes under good control, like if you don't get that down to 18%, we're not going to pay you, or we're not going to pay you whatever extra amount we might have otherwise. But when you look at this and you were then to adjust for the US mean or the social deprivation index of 50, in that clinic they would actually have been 17.7% would be kind of the rate under control. So what we were kind of looking at is like, the more socially complex your patients are, again, pretty obvious, the harder is going to be for you to get their diabetes under good control. And this is kind of just showing it with these really large data sets. And then looking at if we were to adjust appropriately for social complexity, 25% of community health center clinicians would have a 1 to 2% improvement in these scorecards, and 45% would have a 2 to 5% improvement, and 5% would have more than a 5% improvement. And it seems like, oh, 1 or 2% doesn't really matter, but the way some of the payment happens now is it might be the difference between you getting paid or not getting paid, or getting paid an additional amount or not getting paid that. And so where that really matters for me is that we have to advocate on the policy level that, like, if you're going to take care of more vulnerable patients, you need to be, in my opinion, paid more and have more resources to get them to the same levels that someone who has more affluence and luxury in their lives is able to get to. So that's been kind of like using research to then advocate on the policy level of how we can get additional resources for community health centers and people that do provide the safety net. Again, a lot of us might not believe that, you know, just having a safety net is ideal and not enough, but certainly we need to protect our safety net because that's where a lot of our vulnerable people go, and that's their only option to get healthcare right now. This was another piece that we worked on as well, where we were just looking at, you know, does social deprivation index matter in if you have like a patient that's in a less deprived area versus a more deprived area, and you do something else for them, like give them health insurance, does it really matter more or less? And in this one, it was interesting because now we're starting to look at not only did we check their blood pressure, but was it in the optimal range. And surprisingly enough here, when we just looked across the whole population and we looked at like who gained health insurance coverage after Obamacare was passed in a lot of states and states expanded Medicaid, it did look like people who gained insurance, so those that were newly insured, it did look like the likelihood that their hypertension got under control did go up. So that was good. And then what was more interesting in some ways was when we looked at whether they lived in a less deprived neighborhood or a more deprived neighborhood, those in the more deprived neighborhood benefited significantly more. So you'll see the blue dot that goes down, that, you know, the likelihood of their hypertension being in control goes from, you know, 53%, like all the way up to almost 70%. So there was a 16% improvement in the blood pressure of those patients living in the most deprived neighborhoods just by them gaining health insurance coverage. And why would that be? Well, certainly health insurance coverage is going to get them access to care, medications, potentially other services that will help them control their blood pressure. And then, so that was kind of another argument for like, gosh, you know, we probably should know this information about the deprivation index or the community vital signs where the patients live, so that we could potentially identify, like, if you can only help 20% of your patients, these might be the ones that you want to start with because they're living in the most deprived areas. They're the ones that need the health coach, and they're the ones that need help with their medications and other things. So bring all that information into the electronic health record, understand your patient's community vital signs as well as their biomedical signs. But then it's not just about like, oh, bring me in this giant like healthcare system more information and more data. No, I think one of the other really exciting things we're now doing is it's not just about bringing data into my electronic health record. It's about how do we take data that I have and aggregate it and share it out of the health record into communities. So this was one, again, I've done a lot with health insurance, so a lot of these studies were looking at that specifically, but you could do this with percent of people with diabetes, percent of people with obesity, percent of people with opioid use disorder, whatever. But in this case, what we did is we looked at the children without health insurance in our clinics. And we knew that because when someone comes to my clinic, I know whether they have health insurance or not. So I can kind of identify, all right, these are the children without health insurance. Let's put them on a map. Let's figure out where they are. And then let's layer over that the area with median household incomes where almost all those households should qualify for health insurance. So, right, they don't have it, but they likely qualify for it. And then let's go partner with community organizations in that area, in that zip code, to try to help get them the health insurance that they likely qualify for and are not enrolled in. More recently, lots of examples of this. This is colleagues of mine in Virginia. When COVID-19 hit and all of the counties were scrambling around to figure out like, where do we need to put resources, who's going to be hardest hit, before we started seeing all the maps that we're seeing now, they put this map together. My guess is it probably layers almost perfectly on the maps that we're seeing now. They said this is where all the resources should go because these are the communities that are most vulnerable. Unfortunately, even all the resources went there, those communities have probably been the hardest hit, or almost, again, it's probably almost going to be nearly equivalent in those two maps. So where do we go? How do we keep doing this work? How can we do this work in places where people live, work, and play? These are all the big hospital buildings that are being built, especially all over the place and certainly on the Hill here in Portland. And I was just being a little bit radical about, you know, let's build some more bridges from those hospitals to communities. Maybe not tear down a building to build a bridge, a bit radical, but who knows? So maybe not quite that radical, but so I've been spending a lot of time advocating for building different kinds of laboratories. We have 20th century laboratories, which supported amazing science of disease. And we know so much about diseases, we know so much how to treat them and cure them. And so I feel like a lot of the work in the 21st century is going to be in community laboratories where we're supporting the science of health and supporting how to keep people healthy so that they're not developing a lot of those diseases that thankfully we know more about treating, but working upstream from the disease and chronic conditions. And this is another development that we've shared with our institution and begun to work on. And as Olivia mentioned, we did just get awarded a center grant for doing what's called dissemination and implementation science. And that's really looking at like, what's an evidence-based intervention that you need to get to a population of people, and then what are the implementation strategies that are going to be most effective to implement it and implement it equitably. So we know that there's a lot of things recommended in primary care that we're not doing. And I even showed you that grid of like, look, some health centers are doing it for everyone and some are doing it for almost no one. So there's a science to like, how do we get all of these interventions implemented completely equitably? And then there's a lot happening in community labs, which are for us this amazing practice-based research network of primary care clinics and community health centers across the country, and also a lot of community classrooms. And that's, you know, the clinics that we that I oversee here at OHSU, where medical students and nursing students and pharmacy students and all kinds of students learn in, and then our medical residents learn in as well alongside our faculty here, and lots of those. Getting back to the question about, you know, what do we need to do to change policy and payment so that we can implement more community-oriented primary care? Again, this is the CARCs in South Africa, again, through my graduate work. Jack Geiger, who started the centers here in the 60s, had worked with Sydney and Emily Kark, who developed some awesome community-oriented primary care concepts and then centers in South Africa in the 1940s. So I got to go back and visit some of the places that they had started and learn about some of the ideas that they disseminated around the world. Here's kind of a long-winded explanation of what community-oriented primary care is. And again, people are talking a lot about this now, like provide care in communities, for communities, and with communities. But believe it or not, the Karks were doing this in South Africa in the 1940s. So there is a long history and a lot of really great ideas that we have new windows of opportunity to further implement. Talked about the big data, linking what we know within our clinics with communities, and then having our communities as learning systems. There's been a lot happening in big healthcare systems about learning healthcare systems, but this goes that next step to like a learning community and what kinds of data and resources. So this was a report published 10 years ago that is really still very novel and innovative in what it recommended to our government that we need to be doing with our data. I think we're just about to the end, but this was another exciting concept. There was a $100 million challenge to identify a big problem and write a grant to address it. And this was the first, I believe, and only grant I've written that required a video. So I have this to show for it. Of course, we didn't get the grant, but it's still really an exciting project that we're doing little bits at a time.
Our collective inability in the healthcare system and society at large to address social determinants of health has perpetuated a huge problem. Despite spending trillions of dollars on healthcare, we're leading shorter lives in poorer health. More than traditional medical care and biomedical science, how we handle social determinants of health can make or break the future of global health and healthcare. We'd like for the social vulnerabilities to be integrated within a patient's medical record for all primary care healthcare teams in order to impact health. We've decided to call this project Uncharted, Uniting Community Healthcare and Revolutionary Technology to Eliminate Disparities. We've got many folks on our team that have tested blueprints around their communities and around the globe already doing this.
It's the ideal thing to make the person more whole when they have their medical issues done, but yet when they have those outside issues taken care of too, makes them a whole person, makes for a healthy community.
If we could build on many of the pilot projects that our teams have been doing across this country, we could move closer to a solution to this huge problem. This solution requires an infusion of technology, infrastructure, training, policy changes to transform our patients' and our population's health. Rock on, sister.
So I spoke earlier about the Precision Medicine Initiative. NIH has put a lot into understanding our genetic code. So we've been urging them to also fund Precision Community Health Initiative that really helps us bring zip code into health and make decisions that are personalized and tailored based on that in order to improve health as well. And then, as I mentioned, once we make a discovery, how can we scale it up? So this is the new Center for Dissemination and Implementation Research, and working in this implementation laboratory and doing small scale research studies, and then understanding what strategies are going to be most effective to implement new interventions. And they don't have to be flashy new interventions, and could be something as simple as colorectal cancer screening and making sure that people do a stool card that they're turning in once a year in order to assess for signs of potential cancer, or getting their mammogram, or getting their flu shots. Soon it'll be getting their COVID shots and getting their COVID shots again, most likely. So, but there's a lot that still needs to be learned to understand what is going to be most effective, and again, for all populations. So that's why we're really focused on working in this community health center lab and understanding where the disparities are, and then how we can close gaps to achieve equity for that population. And I think this is the last slide, but it really gets back to when I started work and interviewed a number of parents about what it felt like to have an uninsured child and how important health insurance was for them and their families. Oop.
So suppose you were in front of a group of doctors or health policy makers. What would you tell them?
I would tell them, you know, maybe they've never seen the other side before like you have. Maybe they've never been poor or had to live in their car or had to stand in line for free food, or, you know, maybe they've never been there. So maybe they need to walk in, you know, those people's shoes and hear from those people, because it's real. And I mean, I don't, like, you could walk into my house right now and not think, gosh, this lady is not poor, you know, but I have $2 in the bank, you know, right now, but I feel like there are people out there that do live, like, to take advantage of things, but there are people that really just, you know, want to provide the best, you know, home that they can for their kids in the best environment. And part of that is being able to, you know, treat their kids when they're sick and not have to worry about where the money's going to come from, or it being garnished from their wages, you know, 2 months down the line or 3 months down the line if they can't make the payment to it. I mean, health coverage is important, but it's expensive, you know.
All right, and thanks to all these various places that have funded our research and our clinics and patients, and thank you to you for listening. And I have an amazing team, and we have a lot of fun.
Thank you so much, Dr. DeVoe, for taking the time to just share with us. We've had so many students like show so much interest in learning more about like the health and just healthcare system and all of that. So really, thank you so much for taking the time with us today. So yeah, so like we mentioned at the beginning, if you guys have any questions you would like to ask, either just unmute yourself, ask Dr. DeVoe, or put it in the chat box. For those of you who unfortunately have to head out pretty soon, I'll give you guys the attendance. But yeah, so Dr. DeVoe, if you would like to take any questions that might come into the chat box.
Yeah, so the one that came through about what steps our country can take, I mean, I think, and believe it or not, one of the biggest steps taken in my lifetime was Obamacare and expanding insurance and making it more affordable. And I mean, it's a small step, but it is one step. So that's been something that's been exciting to see the expansions there. Having lived through the Clinton era when we tried really hard to expand healthcare and it didn't happen, it was great to see Obama and his administration make some steps in that direction. It's still, again, far from being universal. It's far from being affordable. And so really studying what's happening in a lot of other countries and understanding that you can cover everyone, you can provide services to everyone in actually a much more affordable way. So we're headed in that direction, hopefully, in this country. But I think the other message and what I'm learning is, you know, it's really goes far beyond healthcare. So all the other sectors contribute to health and making sure that you have a strong community and a strong education system and housing that's affordable for everyone, because otherwise the healthcare is going to become even more unaffordable, because as people are homeless, their health problems go out of control and it's even more difficult for them to get their health under control and the costs go up even more. So it's working upstream. So that's where a lot of us are like, let's work upstream and make sure people have healthy living environments and, you know, affordable access to things like education and housing and food, and really understand the importance of that, and then have equal opportunities to be healthy in their lives.